Thank you, Chairman. Thank you, panel. So I'm going to be discussing functional impairment with restricted range in the knee and also when you have impairment of the hip and upper limbs. So just to start with, we'll have a look at what normal range of motion is in the knee. So if you take an electrogoniometer, such as this group in the UK did, and you apply it to age-appropriate individuals for a knee replacement and get them to perform activities of daily living, you'll see that the flexion range will go up to 120 or past that degrees. If you then take case-matched individuals with osteoarthritis, you see a significant decrease in the range they undergo during activities of daily living. In this study, it was about 30% decrease as to the normal case-matched individuals. And you also see a very significant range between individuals when you have an arthritic group of 70 odd degrees for some tests. This same group, the same cohort in the UK, followed a group post-total knee replacement, and they looked at how much of that lack of function they recovered, and they showed that it was about, in their study, 2% or so. So they didn't actually regain much function, and they still retained, so they were still significantly less range with their activities of daily living than in their contralateral limb, and they didn't approach anywhere near the normal case-matched individuals. So we have in our arsenal for total knee replacements high flexion implants, and the question in current literature is, do they actually provide an advantage? But I suppose another question that should be asked is, what's the functional limitation that we're actually trying to address if we're saying, okay, we need more flexion in the knee replacement? When looking at patient expectations, we know that patient expectations are very high. They're usually unrealistic for total knee replacements. And the things that patients want after knee replacements is they become dissatisfied when their expectations aren't met. So if you look at what they are expecting, you find a lot of it's functional things. It's not just high flexion in the knee. There's a lot of influence of being able to perform activities of daily living. But then that brings us back to what we have in the literature, and there's not a great deal of evidence that looks at range in the knee and the patients overall. So we know that from one or two basic studies, if you have restricted range in the knee, you may need to increase your forward flexion of your hips, but then there's no evidence to say, well, how function limited are people that have hip restriction and knee restrictions. Similarly, if you look at upper limbs, then you can't find any evidence that says, okay, if we have a patient who's severely limited in the knees, how limited will they be if the upper limbs well? So we thought of this concept, and we thought we'd design a small study, and all we wanted to show was that introducing restriction in range at hips and in upper limbs has a significant effect on participants or patients if they have pre-existing functional limitation at the knee. So we gained ethics approval, and we recruited 40 individuals that had no other orthopaedic complaints. And we had a custom-built hip and knee orthosis that could be locked at the knee at varying ranges, and we also set a flexion range that could be locked at 90 degrees at the hip. And we used goniometry to monitor the actual range, because we know that the actual braces have variance of up to about 15 degrees when they're towards extension from other studies, but a goniometer is fairly accurate at recording the range of the knee. And we then got the participants to undergo activities of daily living, so we got them to perform tasks such as walking, getting up and down from a high chair or a low chair. High chair was defined as a chair between the lateral condyle and the GT. A low chair was at the popliteal crease, and we had them walk up and down stairs. We increased as a control the flexion limitation of the knee unilaterally and bilaterally, and we took that as a control for the 40 individuals. Then we introduced the variables. So the variables we introduced were no use of the upper limbs, limiting the hip flexion with the brace to 90 degrees forward flexion, and then seeing whether compounding both had an effect on patients' functionality. If you look at gait, obviously upper limb and hip limitation is going to have very little effect on the gait within 90 degrees of flexion at the hip. and all participants could mobilise effectively. For stairs, the only real result there that we found is of interest was that at 45 degrees of flexion, bilaterally, all participants could get up and down stairs, which is, I suppose, interesting for us if we have patients with poor range post-operatively. That it's less likely to be stairs, which is going to limit their ability to perform activities of daily living. High chair we didn't get significant results from, other than once again just interest facts to show that if you have a high chair, even with complete restriction of flexion of the knees, patients are able to, or participants were able to mobilise. But we were really looking at the low chair characteristics, and we know that this is where the greatest excursion of the range of motion at the knees likely to be used or is used, and also flexion at the hips required. And when you look for, when we were looking at patients with unilateral restriction, if you completely restrict a otherwise normal participant's knee, we don't let them have any range of motion. We found still all our participants, if they had normal range at the hips and upper limbs, could still undertake this task. And even with bilateral restriction down to 45 degrees of flexion, so this is, they can only bend to 45 degrees. If they've got good upper limbs and they've got no restriction at the hips, then 80% could still maintain a standing position. But the minute you start to introduce restriction of upper and lower limbs, and especially if you introduce both upper and hip restriction, notice about a third of patients couldn't stand, or a third of participants couldn't stand with a single limb that had no range. And then I suppose more relevant to us too here is if you have participants who only have 90 degrees of flexion range, which a lot of our have, then with upper limb, no use of upper limbs and poor flexion range at the hips, then about a quarter won't be able to undertake the task of being able to stand up from a low chair. Under chi-squared analysis, then all three results reach significance. The upper limb restriction by itself only just reached significance, it was 0.W, but became more significant for, this is for the low chair exercise, to say that yes, this had an actual effect on the results. And now interpretation, and all we wanted to show from this presentation is just that we really should be looking at hips and upper limbs with both research and also our patients that come through. We know patient expectations to be functional, and if we are able to counsel them about how functional they're likely to be after a knee replacement, if we know they've got limitation in hips and upper limbs, we need to help them realign their expectations and also